Hello, thanks for joining us today for our July Masterclass. I'm your host, Zoe Esther. Today, we're delighted to be joined by Professor Esther Florin, a Lichtenberg professor in Düsseldorf. Before we start, a quick reminder to please use the button on your screen to ask any questions. There'll be time to answer those at the end of the session. If you'd like to revisit any part of the talk, the Masterclass will be available to watch on demand by visiting the MEG website and will also be emailed to everyone who registered. Now, without further ado, I'm pleased to hand over to Professor Esther Florin, who will officially begin the masterclass. Thank you.
Thank you, Zoe, for introducing me. And today I will cover a bit of a different topic, I think. It's about MEG to gain insights into Parkinson's disease and its treatment. So Parkinson's disease as a start is characterized by 4 cardinal symptoms. The first one is tremor, which is usually a rest tremor. This means it stops as soon as a patient initiates his or her movement. Then we have rigidity and bradykinesia, so a slowness in movement. And the fourth one is postural instability, shown here, where the patient has his smaller steps and forward-leaning posture, which can lead to falls quite easily. In addition to these motor symptoms, nowadays more focus is also put on the non-motor symptoms, which many patients also encounter. The hallmark or Parkinson's disease is caused by a depletion of dopaminergic neurons in the substantia nigra pars compacta, and therefore the treatment with dopaminergic medication is very successful in the earlier stages. Dopamine in itself is a widespread neuromodulator in the brain, and this, on the other hand, raises the question whether it only restores normal function in every domain of the Parkinson patients. In Parkinson's disease, it has therefore been shown that dopamine can lead to cognitive side effects. And these findings have actually led to a hypothesis on dopamine overdosing, so that basically the excess of dopamine in brain regions which are not affected by Parkinson's disease, which are not related to the motor symptoms, are having too much dopamine available. And therefore, task-based neuroimaging studies have shown that dopaminergic medication can lead to frontal cognitive impairment. In addition, as Parkinson's disease progresses, many patients experience what we call on and off fluctuations in their mobility, meaning they only have short phases in which the dopaminergic medication really works well for them. And in these patients, the brain stimulation is a good option. For this, stereotactically, electrodes are implemented into the subthalamic nucleus, which is part of the basal ganglia. By then applying high-frequency stimulation in the range of 130 Hz, motor symptoms can be greatly improved in these patients. On the other hand, this invasive implantation of electrodes provides us with a unique opportunity to simultaneously acquire local field potentials from this deep brain structure and combine it with MEG in humans. Such recordings allow us to study network effects of dopamine treatment and the pathophysiology of Parkinson's disease. So in the following, I will show you how such a resting state network analysis we have used so far to better understand Parkinson's disease and the effect of dopamine. For this, we recorded STN LFPs, so local field potentials from the subthalamic nucleus, which were implanted 1 to 3 days before the actual recordings, in addition to MEG recordings. We recorded our Parkinson patients once after they were withdrawn from their Parkinsonian medication overnight, and once when they received their standard dopaminergic medication. We then used a hidden Markov model to identify fast-changing networks comprising both the STN as well as the cortical areas. Through this analysis, we identified 6 states which of which 3 were very well interpretable, and I will present those in the following. First of all, to orient you in those figures, we have here these ring figures which represent at the bottom in blue the recording sites in the subthalamic nucleus, and then going from the back to the front, we have first in red the visual cortex, then the parietal cortex, SMR, temporal cortex in purple, and yellow prefrontal cortex, and in orange in the front, the frontal cortex. We identified then the coherence between all of these regions for each state in the 3 frequency bands we describe here. So in the delta theta band, the alpha band, and the beta band. At the top, we see the network of medication, and at the bottom, once the patients receive the medication. And what we can see that on medication, we actually have a strong coherence in the frontal areas, which is not present off medication. On the other hand, we don't see many connections on medications in the alpha and beta band, whereas in the off state, we have those connections within the STN. Overall, this finding that we have frontal connections in the on medication state is in line with this Parkinson's disease overdose, dopamine overdose hypothesis, whereby this excess dopamine for the frontal areas leads to excess communications in the frontal brain areas. The second state I would like to highlight is the we term the communication state. And in this communication state, the communication between cortex and the STN was reduced on medication, versus in the off medication state, we see a very strong communication, especially in the alpha and beta range. Also in line with previous research, which used a more static approach, we see a switch from a STN mediated motor network, so we see the connections from the subthalamic nucleus to the motor cortex off medication, to a more frontal parietal motor network on medication. The third, so as I said, these findings are in line with the classical time coherence analysis, which was before done in Parkinson patients with similar recordings. The third state I would like to highlight is the so-called local state, and we termed it the local state because we found mainly communication within the STN. Interestingly, we found this communication across all frequency bands of medication, but as soon as the patients receive their medication, we see a loss of delta STN-SDN coherence on medication. This finding is backed up by findings from mice, where it has been previously shown that local basal ganglia delta oscillations, which actually do not require any input from the motor cortex, are a robust biomarker of dopamine depletion. So this selective elimination of delta theta oscillations under dopaminergic medication in the STN or our local state points towards a restoration of physiologically relevant network activity. As I said, as the disease then progresses, many patients experience these on and off fluctuations, and in these situations, deep brain stimulation is a viable treatment option, and it usually leads to good motor improvement. So far, I only showed you the use case where we externalize patients after they undergone the deep brain stimulation implantation, but of course it is also of interest to understand the network effects of deep brain stimulation when we record these patients in the MEG. However, deep brain stimulation is a train of pulses with a particular frequency, which you can see here. So usually in Parkinson's disease, we use a frequency of 130 Hertz, and as it is electrical stimulation, this produces artifacts in our recordings. So here's an example of a recording where stimulation was applied at 160 Hertz, and the problem is that we don't only see the artifact at exactly the stimulation frequency, but we see aliased frequencies in the lower frequency band and in the upper frequency band. When we then look at actual patient recordings, the picture becomes even more disrupted by the deep brain stimulation. So this is an example power spectrum of a Parkinsonian patient. And we see here on the one hand the actual artifact from the deep brain stimulation, but on the other hand, in the blue line, we see that we have an increase in the lower frequency range. And this is actually due to the movement. So just by the fact that we are breathing and we have arterial pulsation, the cables and all metallic parts which come with the DBS device are going to produce artifacts in the MEG. And therefore, because we are also mainly interested in this lower frequency range, it is important to clean our MEG data. And there are nowadays several methods proposed to reject these deep brain stimulation artifacts. One is a Hempel filter. Then we have spectral signal space projection, temporal signal space projection, TSSS, which many of you probably use in the form of the MEG filter, then independent component analysis in combination with mutual information. So here a signal is recorded in addition, which records the stimulation artifact, and based on the mutual information, we can eliminate components which contain mainly the artifact. However, what was missing is basically a comparative study with a ground truth to objectively evaluate these methods. And for this, we performed a phantom study. And here you can see our phantom, which is a spherical container filled with saline solution. We have a dipolar source which emits a signal at 12 Hertz, and we have a DBS electrode inside with bipolar stimulation at 130 Hertz. And in addition, you can see here, we have something which mimics the arterial pulsation with a pneumatic apparatus. So this phantom goes into the MEG, and we can record now the activity of the dipole and also all the artifacts the DBS electrodes are producing. So for this phantom study, in terms of pre-processing, we first needed to remove the very noisy segments and, of course, channels which went out of their range from the data. Then we used a beamformer to extract source level activity, and we looked at the power spectrum with Wells method to identify, on the one hand, the artifacts, and on the other hand, to see how our cleaned data would look like. So now let's look at the sensor level. So this red line is basically our reference signal. So this would be an empty room recording, more or less, with a phantom in it, with a 12 Hertz bipolar source, but no artifacts. So if we now turn on the deep brain stimulation, we clearly see that we have an artifact at the stimulation frequency, but we also have this increase in the lower frequency range due to the movement of our phantom. And now we tested different cleaning algorithms. So the first one is an Hempel filter. And as you can see here, the Hempel filter didn't do much to the lower frequency range, but it nicely removed our DBS artifact at the DBS frequency. Then we looked at S3P, so signal space separation, and here again we have the same effect, that we are not removing the movement-related artifacts, but only the DBS artifact. Looking then at independent component analysis with mutual information, we clearly see that it now removes the DBS artifact. Maybe there's a small reminder, and we can see that we also remove to a large extent the movement artifact. Importantly, we also preserve the dipole amplitude. The last technique is TSSS. TSSS seems to have a similar effect as ICA with mutual information, but it reduced the overall noise baseline, so it dropped the whole power downwards. From these data, we concluded that if we want to remove not only the DBS artifact, but also movement-related artifacts, we would need to use either ICA mutual information or TSSS. And so we moved on and looked into actual patient data and evaluated it, ICA mutual information and TSSS. And here are two exemplary subjects or participants. And what you can see here is in this black dotted line, the MEG with the deep brain stimulation turned on, and in blue, the data cleaned with ICA mutual information. Here, contrary to what we saw in the phantom data, we see that the noise baseline was significantly increased in the resting state recordings. And in addition, any movement-related activity, so here at the front, was not reduced by ICA mutual information. In addition, again, also contrary to what we saw in the phantom, the electrical disturbances were only minimally suppressed. So we went on and evaluated now TSSS on the same two participants. And what we can clearly see that TSSS selectively suppressed the movement artifact. We again see this little shift in baseline activity. And also here the electrical disturbances are not suppressed. So looking then back at our phantom data, where we saw that the Hempel filter really well removed the DBS artifact, and on the other hand, we have the TSSS seemingly well removing the movement-related artifact, we suggest now a new approach to combine for the cleaning TSSS with a modified Hempel filter. And this looks like this. So we do first TSSS on our MEG sensor data to remove any movement-related data. Then we do source imaging, the reason being that when you only remove on the sensor level the DBS artifact, you still see remainders in the source reconstructed data, whereas if you do this on the source reconstructed data, you have a better chance of completely removing the 130 Hertz artifact. So we use the short time Fourier transform, we detect the outliers, and we replace the outliers with the median, and then we do the inverse short-term Fourier transform and obtain the denoise data. So looking now at some real data, we have here a recording of, again, an exemplary participant where we see several peaks. So these are the different ELISed frequencies, and our Hempel filter detects those outliers, marks them, and would replace them with a median. So this gives us in the end, on average, a power spectrum with nicely removed DBS artifacts and ELISed frequencies. And if there are no movement artifacts, we don't see a shift in the lower frequency range. If there would be movement artifacts, we could also remove those with TSSS. So to conclude this part, ICA in combination with mutual information and TSSS seem to outperform all other methods in the phantom recordings. However, when we moved then to real-world data of resting state recordings, ICA mutual information did not perform well, and therefore we suggested then a combination for cleaning our MEG recordings with DBS artifacts by using first TSSS and the sample filter to suppress DBS artifacts in resting state MEG data. And this approach made it then for us possible to investigate DBS effects and measure in the MEG. So this is what we did next. We did a whole study looking into the network effects of deep brain stimulation in Parkinson's disease. For this, we recorded 18 Parkinson's disease patients. These patients were recorded 30 minutes each in the MEG at rest with eyes open, and we recorded them in 4 different conditions. So we recorded them once with the usual dopaminergic medication and in that state on and off DBS, and we recorded them once after overnight withdrawal of the dopaminergic medication and again once on and once off DBS. We then cleaned our MEG data with TSSS and a Hempel filter, and we extracted the resting state networks based on a phase amplitude coupling approach which we had proposed before. Based on this approach, we identified 4 resting state networks. So those 4 you can see here. The first one is a visual network. Then we have a more frontal network, auditory network, and a sensory motor network. We extracted those networks for all 4 states, so medication off, stimulation off, first row, medication off, stimulation on, second row, medication on, stimulation off, third row, medication on, stimulation on, fourth row. And now, of course, the interesting question is how the brain stimulation and medication change these networks. And for this, we did statistical comparisons between those conditions. So first of all, for the frontal network, we compared the medication off versus on state, as well as the stimulation off versus on state. And in the frontal state, we see that stimulation and medication both increase the frontal activity, here especially in the right inferior frontal cortex. This might be related to the right inhibitory network, which has been related to akinetic symptoms, and therefore specific alterations of both medication and deep brain stimulation could indicate or could lead to improved performance here. Then, of course, the second very relevant network for Parkinson's disease is the sensory motor network. And what we found here is that stimulation and medication increase the frontal activity, you see here. And interesting, for the medication, we see also a decrease in posterior areas. We had done before a study with EEG in Parkinson patients, where we also could show a shift of the motor network from posterior to frontal areas with medication. And here we see that this shift is specific to the dopaminergic medication, versus the frontal changes are also present in the stimulation condition. Now, concerning the visual network, we see that deep brain stimulation increases activation in the ventral pathway, while medication reduces it. Overall, clinically, it is not so clear. So Parkinson patients do have some visual impairments, and it is not clear how they are modulated by treatment. And based on these findings, we can also not clearly state which whether medication or deep brain stimulation would work better here. The next network is the auditory network. And here we see again the same effect of both medication and stimulation. So stimulation and medication reduce here from functional connectivity. And this is actually in line with evoked studies in Parkinson's patients. So in Parkinson's, it has been shown that the N100 amplitude is increased and that the brain stimulation and medication seem to reverse such effect. So basically improving also the auditory perception. So far, I have tried to show you that with MEG, we have the possibility to study network effects in Parkinson patients, both with STN-DBS as well with medication. In terms of clinical use, however, it would be, of course, also quite interesting to see that MEG could also be useful in helping clinicians either to predict disease outcome or improve treatment. And one way of looking at it was for us through cortical evoked responses due to STN-DBS. So in humans, previous studies have primarily used ECOG or EEG over sensory motor regions to study these cortical evoked responses due to STN-DBS. And these studies have identified different latencies of the responses and related the very early responses to the activation of the corticospinal tract, shown here in green, while medium latency responses relate to the activation of the hyperdirect pathway. Importantly, and that's why it might be also of clinical use, the amplitude of these responses, as well as even these later responses, were related to clinical effect and side effects under clinically used stimulation. Therefore, the evaluation of DBS evoked cortical responses may allow one to identify optimal stimulation parameters more efficiently than it is done in current clinical evaluation. So far, DBS settings are evaluated by a neurologist in a lengthy procedure by changing stimulation parameters such as amplitude and the contact over which stimulation is applied, and this can take several hours. The limitation of those EEG and ECOG studies so far is that these were limited to very few cortical locations, and therefore potentially far-reaching effects of deep brain stimulation could not be studied. And we therefore recorded 22 Parkinson patients, and we recorded them with a stimulation frequency of 6 Hz in monopolar stimulation, while we increased the stimulation amplitude of the left STN during the MEG recording. In addition, we assessed the finger tapping, so this movement, while we applied different stimulation amplitudes. The finger tapping was used as a clinical marker of impairment in these patients. When we first now look at the cortical evoked responses due to STN-DBS, we first see a clear evoked response occurring at 12 milliseconds over motor areas and a second later response at 21 milliseconds, which spreads to frontal areas, including the supplementary motor area and the middle and inferior frontal gyrus. We then extracted for these regions of interest the evoked responses for the different stimulation amplitudes. And what we can clearly see is that the first evoked response and the second are modulated or increase with stimulation amplitude for the motor cortex, the inferior frontal gyrus, as well as the middle frontal gyrus. Now the question is, we see on the one hand that stimulation amplitudes leads to larger evoked responses, but it doesn't answer the question as to whether this has any clinical relevance. So now to relate these responses to clinical effects, we calculated linear mixed effect models between the amplitude of the evoked response at 10 and at 20 milliseconds, and we extracted a finger tapping metric. So we've looked first at the tapping frequency, and here we see that the motor cortex M10 response was a significant predictor of the tapping frequency, with greater evoked responses relating to a greater tap frequency. So ideally, deep brain stimulation should also fasten the tapping frequency. On the other hand, when we look at the M20, so the later evoked response, we see both in the motor cortex as well as the supplementary motor area an inverse relationship to the tapping variability. So this means that with a greater evoked response, we have less variability in the tapping, which is also a wanted effect of deep brain stimulation. Therefore, these results are actually a further indication that stimulation evoked responses can inform clinical programming in a relatively precise manner. We show here in particular that different latencies, so the M10 and the M20 response, even resolve these small differences in tapping frequency as well as tap variability. Stimulation amplitude is one parameter which needs to be adjusted individually. The other parameter is the question of where to stimulate. And now, therefore, we went on and also analyzed the effect of changing the stimulation location on these cortical evoked responses. Here we particularly focus on what we call directional stimulation. So newer DBS devices, so this is a DBS electrode, older devices only had 4 contacts, and newer DBS devices have 2 contacts, which now allow to stimulate in 3 different directions on these 2 middle contacts. And this direction of this administered current could actually influence the clinical benefits, reduce side effects, and therefore optimize the therapeutic window. As you can imagine, however, now we went from 4 potential contacts for clinical stimulation to 8, which means it increases further the search space for deep brain stimulation. And therefore, the need for more objective and faster ways of evaluating optimal DBS has emerged even further. So now looking at the different directional contacts, we evaluated these evoked responses again. And we used exactly the same setup as in our previous studies. So we measured MEG while using this low frequency stimulation in the subthalamic nucleus. In addition, we assessed again finger tapping under these different stimulation directions. However, while we focused before really on the already selected optimal contact, we now tested all different contact orientations. And what we found here in terms of source imaging is again a robust DBS evoked response at about 16 to 26 milliseconds, which was located in the sensory motor cortex ipsilateral to the site of stimulation. Remember, we stimulate here for these studies only in the left hemisphere. So next, we investigated the effect of contact contact direction. And for this, we first sorted the different contacts. So we first of all identified the contact which was clinically used, shown here in gray. And then we had one contact pointing to the anterior direction, one to the medial, one to the lateral direction. And then we have also the so-called omnidirectional stimulation. That would be the classical ring-shaped stimulation. And what we see here is that the amplitude of the SM1 evoked response is significantly larger for the clinically chosen contact compared to the omnidirectional as well as the lateral direction. So this is again an indication that larger SM1 amplitudes could index the optimal stimulation setting. Now again, to assess whether this is also related to clinical effect, we again went on and looked into the finger tapping metric. And here in this study, we didn't use each parameter of the finger tapping separately, but we generated an overall finger tapping movement profile, which in the end contained acceleration magnitude, variability, and tapping frequency. And it was coded in such a way that lower finger tapping movement profiles indicated a faster and smoother movement, so the preferred way we want the finger tapping to change. And then we looked at the relation again to the SM1 amplitude here shown on the x-axis. And what we can see is that for the clinically chosen contact, we see a higher SM1 amplitude for a lower finger tapping movement profile. So again, indicating that higher SM1 amplitudes also relate to a better movement outcome. And this was particularly also significant in comparison to the anterior contact. To summarize this part, we here observed that sensory motor evoked responses were larger during clinically effective electrode configurations, and that the finger tapping was smoother when stimulation occurred via the optimal electrode contact. So more specifically, larger SM1 responses were predictive for better behavioral metrics in a contact-dependent manner. This suggests that both DBS evoked responses as well as quantitative measures of finger tapping could provide novel insights regarding the optimal electrode directionalities that are necessary for elevating impairment in patients with PD. So to summarize my talk, I have shown you first that MEG allows us to gain insights into the electrophysiological mechanisms underlying Parkinson's disease and dopaminergic treatment. We looked into dynamic network effects in particular, and we saw that we gain insights into network effects of disease and tremor, and we saw both positive and side effects of dopamine and Parkinson's disease based on these dynamic networks. Then moving on to deep brain stimulation, looking again at the network effects, we saw that deep brain stimulation as well as medication differentially alter the resting state networks, and therefore we need to carefully evaluate what is the wanted effect of both treatment options. In terms of looking then at more clinically more translatable results, I showed you findings on motor cortical responses, which could be predictors of motor performance and clinical parameters. So we saw that these cortical evoked responses could be a marker for optimizing deep brain stimulation, both in terms of the contacts used as well as the stimulation amplitude. with this, I like to thank you for your attention, and I also like to thank, of course, my lab members and for doing all their great work which I presented here. So thank you.
Thank you very much for your presentation, Professor Florin. We now have time for some questions. Please feel free to submit your questions as we go along. So the first one we have, can evoked responses due to stimulation also be applied in other diseases? And can this be used to optimize treatment in those diseases?
Yeah, so actually there have been studies in dystonia patients where the stimulation target is a different one, so the globus pallidus pars internus, where evoked responses were described. It hasn't been evaluated as systematically as it has been done in Parkinson's disease, but we are actually currently looking into this question as to whether dystonia patients, or whether in dystonia patients we could also use these evoked responses recorded with MEG to optimize the brain stimulation settings.
What would be a way to implement evoked responses into clinical practice?
Yeah, so I think it will need, on the one hand, a more or a larger study cohort, meaning we so far have looked into roughly 30 patients in Parkinson's disease where we already see these effects. I mean, to really translate it into clinical practice, we probably will need a larger sample, and we probably need to work together with the manufacturers of these DBS devices so that we are able to swift through all of these different DBS settings in an automated manner. So at the moment, basically we all manually change each setting, which takes time. And the idea would be that we stimulate at each setting roughly 30 seconds to a minute. And with that, basically can put the patient in the MEG for, let's say, 10 minutes. And afterwards, evaluate the DBS responses.
We've got another one here. Why did you focus on the clinical characterizations of the Parkinson patients with finger tapping?
Yeah, so usually when Parkinson patients are evaluated in terms of clinical evaluation, we use a unified Parkinson's disease rating scale, which includes not only finger tapping, but also arm, head, legs, and so forth. However, the finger tapping is one of the easiest to evaluate because we have the possibility to record with an accelerometer the actual finger tapping, and it is something which patients can also do in the MEG, versus if we start with like walking, it is not possible to do it in the MEG. In addition, it is usually a good marker of their bradykinesia, and we have also considered to look at other parameters which are evaluated on the hands, like hand rotation, and we are still looking into it, let's say.
Got another question here. Somebody says, although I appreciate all the fantastic algorithms to reduce the DBS related artifacts, it would be better to collect the clean data by preventing the well-known possible noise. Can you recommend a strong protocol to avoid the noise at the stage of recording MEG data?
Well, I mean, yes, it's true that of course it's always better to not have the noise, but I mean, as we are interested in the effect of deep brain stimulation, which is an electrical artifact, we cannot omit basically this artifact. So we have to deal with this data, and therefore we need to use cleaning algorithms. If we would have a population of Parkinson patients without DBS devices, of course we would try to reduce any thought of metal, or in a healthy population, we always make sure that there is no metal, no electric artifacts. But it's basically inherent in the research question, where we want to understand the effect of deep brain stimulation, that we have this artifact.
Is low frequency 6 Hz stimulation effective as a treatment in Parkinson's disease?
No, it is actually not. So yeah, so usually treatment is at 130 Hertz roughly. Sometimes it's changed a bit. 6 Hertz is actually a frequency which the patients don't really notice, and they don't see a clinical improvement. We only use it because it allows us, if we have these, or if we want to look at the evoked responses, we have enough time between each stimulation pulse to look actually at the evoked response. Versus if we would use a 130 Hertz, we would have only such a short amount of time between each stimulation pulse that we wouldn't be able to identify any evoked responses.
Perfect. I think that's all of our questions for today. Oh, let's have a look, quickly check. Got one more here. Do you know of a clinical study that enrolls PD patients for MEG assessment and DBS adjustment?
No, I'm not aware so far. I mean, it's basic research, so it's not yet in any terms a clinically approved way of treatment. Let's put it that way.
We've got one more. Can you elaborate on the reason why the phantom-based algorithms for reduction of noise was not working well for the real subject data?
Yeah, that's a that's a good question. Well, we believe that on the one hand, potentially you saw the pulsation. It might have been a bit too strong. On the other hand, we tried to mimic what we saw before in previous recordings. And the other thing is that, I mean, everything else except for the dipole source and the DBS and the movement is anyways the empty room recording in the MEG. So I assume that all these noise separation techniques have a difficulty because we only have this few actual signals in the data in the phantom, versus if we have a patient sitting in the MEG, we have in addition all other brain signals, which probably allows better separating noise from the brain activity. And that's why I would say probably that's the reason. But I mean, I don't know of a way of proving this theory.
Brilliant, thank you so much. That's the end of our Q&A session. Thank you to everybody. A huge thank you to Professor Florin for your time today and for delivering such an excellent masterclass session. To all our attendees, thanks for joining us, and we hope to see you again soon. Goodbye.
Bye, thank you.